which doesn't show up real well. A couple other things that we changed. We focused on reducing the use of institutions. That upper left is a historical marker of Northern Wisconsin Colony and Training School. That's what it was called when I first started working. And now it has a historical marker of a small unit. There's still a place called Southern Wisconsin Center and Central Wisconsin Center. They're much smaller. They cost $800 a day. They're not a good use of public taxpayer money. They're not cost effective. We have reduced the cost dramatically in our system in the last several years as we implemented family care by at the same time focusing on we need to bring people back home. Our nursing homes have been reduced per capita use quite dramatically through the advent of family care as well as associated programs through our top and KIP programs. I mentioned just briefly in Milwaukee County was a great part of cost effectiveness. In Milwaukee County, pilot experience was helping people come back from nursing homes and stay in their communities, preventing people from going into nursing homes. And self-directed supports were a large component of making that very, very significant. So that is a big design feature that we're continuing to focus on. We talked about ending the waiting list, phasing out the waiting list, which is huge for all the reasons that we know. And we do not need to apologize for being frugal, for doing the best that we can to make our programs affordable. That was the original intent, and to the extent that that intent is not being fulfilled, it's a lot of the discussion we're having today. A lot of reasons for discussion, having a legislative audit committee discussion. We can do better than this. We have learned sometimes that we work. We're also learning that some things we do don't make sense. Don't make sense. So there's sins of omission and sins of commission that are going on right now. And as we talked about this morning, we have to prevent them. But the original design of the program had these features. And what I want to point out here is that these features did not come from the Department of what was then Health and Social Services. The original design for long-term care reform was not what we now see as family care rights. Some of you were probably part of the Ben-Hur cast that was asked to come together to develop family care. I doubt that any one of you who were part of that work in 1995 and 1996 said, you know what we would like to do was we would like to replace our county long-term care program with a large insurance company from out of state that would come in and run the entire system. But yet, one morning, I was part of the management group within the department that met 6-7 hours a day, I think, for part of this time, and I'm getting all the input from stakeholders. A secretary came in from the department one morning and announced to us that you folks have got it wrong. Here's what we're going to do. We're going to combine all of long-term care, all of acute care, all of primary care in one bundle, and we're going to bid it out to a couple of private health care organizations. They can be from Wisconsin, they can be elsewhere, but it's going to be a statewide program. No pilot, no county involvement, no local involvement. That is the program that went out to public hearing in 1997, early in 1997. And the citizens of Wisconsin spoke loudly. And some of you may have been part of the speaking loudly group saying, that's not what we want to do here. That's not what we said when we invited this to state federal groups. Public hearings, I think there were two. I mean, the first one was in Green Bay. I think there was a second one in Wausau. I hate to schedule. Governor Thompson called the department and said, I want you to cancel the rest of those public hearings because I'm not going to do this. People are overwhelmingly saying this is a bad idea. I want you to go back to the drawing board. Come back to the drawing board. We went. And when Lynn talked a little earlier about, when Governor Thompson said to him and to Lynn Fraser and to Craig Thompson, and he also said it to other people, is this something that I can take to the legislature with your support? It was the design that you just saw. And that design was based on input from people with disabilities and their families, from elders and their families, from service providers, from county government. And that design said, We're going to go locally. We're going to build these programs locally. We're going to pilot them in a number of places. I think some of the input also, as Representative Rhodes said this morning, came from legislators who were very insistent on a pilot. So I bring this up not to say, that Oz was a bad guy. It's just when people think that they can do this from high and have all the answers, it usually doesn't work. And the dialogue that's going on right now is very similar to the dialogue that's a bit of a less intense, but no less important manner that went on back then. With people all getting together saying, at this point in time, hey, now we've got a design between family care and IRIS that can work. The thing is working for lots of people right now. If it's going to work for everyone, we have to work together to make that happen, to make that a reality. There are things to worry about. The U.S. Department of Health and Human Services wrote a report on managed long-term care. And they said one of the things we need to worry about is states have to monitor member outcomes very closely to ensure that managed care contractors are not cutting services and costing appropriately. Those of you who go back a ways, like I do, may recall that in managed health care in the early 1990s, there were lots of concerns. Go back to your computer and Google drive-by birthdays, drive-by hysterectomies, physician gag orders. These were things that occurred during the early rollout of HMOs, of managed health care. The federal government in 1995 had to step in and acted more quickly than the federal government has probably acted ever on anything, with total bipartisan support to pass a law requiring managed care organizations to allow mothers to stay in a hospital for up to 48 hours after birth of a child. They had to pass a law to do that because we had a rollout problem. Managed health care, in most respects, has now been looked at and very successful in most respects. But the early rollout had some friction and had some practices that needed to be addressed. And we need to do the same thing here, and we're in the process of doing that right now. I really, truly appreciate this day that RFW has brought folks together. Susan and others from the department, this is the process that we need to be engaged in right now. We need to continue to look at, if we're going to make this design work, how this is working for members. Shelley mentioned this morning the outcomes. We've almost stopped talking about the outcomes. That's part of the design. Over Shelley, people get to choose where with whom they work, where with whom they live, where they work during the day, what they do during the day. People get to choose the services and supports they receive. These are the hallmarks of our design. And we know when we engage people, engage those who provide support to them, engage their families, their allies, their communities, we can do this. We can create this. The Peonies program, we were talking about flowers over lunch. I was peonies and all that. There's an evaluation system that people have looked at that said is probably one of the best evaluation systems anyone's ever seen to really get at, from the perspective of the member, are those outcomes working for you or not? Are they happening or not? So it's really important that we implement that design in the relatively near future.